I'd like to thank everyone for joining us this evening. If most of you are like me, you probably worked a long day in your office today, and I know during the week, especially for physicians, our evening time is quite precious. So I appreciate you taking some time out of your schedule to join us, and hopefully you'll not only find some useful information about the course if you're considering registering, but also learn a few things about musculoskeletal ultrasound and how to apply that in your practice. So we'll start with the requisite disclosures. I have no relevant disclosures for tonight's talk. First, a little bit about the background of the course directors. For myself, I'm a hospital-employed physician. I'm both a physiatrist and a pain physician. And even though I'm hospital-employed, I work within an orthopedic practice. We have several orthopedic surgeons and physician assistants. There's also another physiatrist in our practice. And that creates, frankly, a very nice referral network in terms of ultrasound referrals, which probably makes me somewhat fortunate in that regard, and some of you may have similar setups or different setups. And we'll talk a little bit later in the lecture on how to integrate ultrasound into your practice if you're not already doing so, and possibly provide some tips in that regard. In terms of my education, I did my PM&R residency and my pain fellowship at the Mayo Clinic in Minnesota, and I was lucky that I was at a residency program that offered formal education in terms of musculoskeletal ultrasound, and was also at a facility that offered high-level ultrasound courses as well as, for example, some of the AIUM courses, and that was very nice exposure during my training. Our co-director, Dr. Pingree, is faculty at the Mayo Clinic in Minnesota, and he has taught and directed many prior ultrasound courses, both for the Academy and other organizations. And his clinical interest, like myself, is in quite a bit of the use of ultrasound for spine, pain, and musculoskeletal procedures. I'll give you an outline of what we'll be discussing tonight. We'll be doing an overview of the course. I'll also be comparing the use of ultrasound with fluoroscopy for pain and musculoskeletal procedures. I'll be discussing some information regarding integration of ultrasound into your practice. We'll be going through a few sample procedures that will be similar to some of the procedures we'll be teaching at the course. The ones I'll present tonight have primarily a musculoskeletal emphasis because of the kind of practice I have, but some of the other faculty that we have at the course that I'll be talking about later will be presenting other kinds of procedures as well, and we're going to try to give you a good mix at this course. Towards the end of tonight's presentation, we'll go over some further course and site location information, and of course also give you a link for registration information as well. So our course will be towards the end of August. We discussed when we were setting up the course when we should host it, and we ultimately decided that we'd like to do it over a weekend, especially for those who are busy and in private practice and find it difficult to get away, that a Saturday and Sunday format might work best for them. We're going to be hosting the course down in Tampa, Florida, and there is a new state-of-the-art facility down there which the Academy has used before. I have not been there, but I have talked to course directors from the musculoskeletal ultrasound course that was done there earlier this year, and it got very good reviews from the faculty as well as the attendees. You can see the registration rates listed here for both members and non-members, and we'll discuss that a little bit more at the end as well. And if you look at the photo in the bottom right, that is actually from the facility itself. It's a very nice new facility. So what should you expect at our course? Of course, there's a variety of different ultrasound courses out there. Some of them emphasize musculoskeletal ultrasound for diagnostic purposes. Some are focused on procedures, and our course is certainly procedurally focused. And what makes our course different than others? There are pain courses out there, there's musculoskeletal courses, and our goal in developing this course was to kind of come up with a hybrid, because we realized there's a lot of physiatrists that do pain, and frankly, if you're in pain medicine, even if you're not a physiatrist, you basically end up doing some physiatry as part of your practice. And so many times, I'm sure you see patients who are referred to you for a cervical radiculopathy, and you decide it's shoulder pain, and vice versa. And I think the same thing really applies in the lumbar spine and for the hip joint. And that's a very common crossover differential diagnosis. And an ultrasound machine in your office can be extremely useful in working through those kind of scenarios. Of course, when anyone's looking at a course, particularly that's procedurally focused, there's always the question of will there be enough hands-on time, and that was a big focus for us in developing this course, and we'll talk a little bit more about that in the next few slides. And it's great to learn things at a course, but you want to be able to integrate it into your practice. And we put a special emphasis in this course, as well as talking a little bit about in this presentation on integrating ultrasound in your practice. So it's not only fun, but it's practical and useful for your patients. We're going to have 14 demonstrations and lectures. All but 2 of those are going to be specifically focused on looking at anatomy and procedures. We're going to start with 2 introductory lectures, especially for folks who don't have a lot of experience with ultrasound, to get their feet wet so they're comfortable with the science of ultrasound and how it works and how it's different from other modalities like fluoroscopy. And in the day-and-a-half course, 7.5 of those hours is going to be hands-on. Some of that's going to be with cadavers, some of that's going to be with live models. And for each procedure and body area we're presenting, you're going to be able to practice it not only on a live model, but also on a cadaver, utilizing a needle to be able to practice that specific procedure. And you will have already seen that anatomy and procedure being demonstrated at the front of the room. Of course, we won't be using needles during the lecture phases, but you will be using them during the cadaver phases. And towards the end of the course, on the second day, there'll be 1 hour of free scanning time, where if there's a procedure that you are particularly interested in or you want to spend more time on, or perhaps there's a procedure that we don't present that you'd like to be able to offer in your practice, you can pull aside one of the faculty and have them go over that with you. There'll also be ultrasound vendors on site with product information and demonstrations. So this is an outline of some of the topics and procedures we'll be covering. You can also go to the Academy website. We have a full course outline there as well, which will give you further information. And I basically want to break up these procedures into categories. Procedures that kind of get that pain heading, so stellate blocks, lateral femoral cutaneous nerve, occipital blocks, intercostal blocks. Procedures that fall under the heading of musculoskeletal procedures. We'll be doing hip and glenohumeral joints, as well as discussing trigger point injections under ultrasound as well. Spine procedures such as epidural injections, medial branch blocks, looking at those in both the lumbar and cervical spine, as well as what I would term crossover procedures. So procedures such as sacroiliac joint piriformis injections, where patients are often presenting with quote-unquote back pain, and ultimately you decide it might be coming from an area that's not the lumbar spine, and you may need to be evaluating and treating the sacroiliac joint or piriformis areas. Now, of course, in a day-and-a-half course, we cannot provide every procedure and teach you every procedure out there, but it is our hope that with the group of procedures we're presenting, you will be able to utilize some skill building. In other words, if there's a procedure you're interested in that we don't specifically present, number one, you might be able to cover that during the hour of free scanning, and when you pull aside a faculty member to have them go over it with you. Or you might be able to just take the skills you learned in the course and apply it to that area. For example, in my practice, I do a lot of trochanteric burst injections under ultrasound, especially in patients with a high BMI who may have failed a prior non-guided injection. And if you haven't done that before, but you're going to learn the hip joint injection at our course, I think you'll be very easily able to apply what you learned at our course and learn a procedure such as the trochanteric burst injection very quickly. Now I'm going to contrast ultrasound and fluoroscopy for pain and musculoskeletal procedures, and hopefully you can see my pointer here. The picture we have here on the left is of the sacroiliac joint under ultrasound. So this side here would be lateral, this would be medial, this would be the ilium, and this would be the sacrum over here. And if you look at this cleft here, this is your sacroiliac joint. So if you needed to inject that under ultrasound, you could introduce a needle through the skin from either over here or over here and visualize that needle going into the joint. And if you're wondering what this is right here, if you're not real familiar with looking at the sacrum under ultrasound, this is actually a sacral foramen, and one of our lecturers will be talking about sacral transforaminals as well under ultrasound. And this is in contrast to a fluoroscopic view of the other side, of a right side. And as I'm sure a lot of you are aware who already do these kind of injections in your practice, artifact can be a real issue with sacroiliac injections. In other words, you're not always sure if you're looking at the anterior or posterior sacroiliac joint under fluoroscopy, and sometimes it's challenging. You bring a needle down there, you think you're in the sacroiliac joint, and you're not exactly where you think you are. As you can see, contrasting that with an ultrasound image, you're only looking at the back of the sacrum, and in this particular patient, you can fairly easily see exactly where you need to go. So it helps eliminate that a little bit. So factors that favor ultrasound versus fluoroscopy. This is actually a picture of my procedure room in my office, and you can see that the ultrasound machine is a lot smaller than a fluoroscope. It really tucks nicely into the corner out of the way when we don't need it. And it's quite convenient to use. It's something we can just roll forward to the bedside. If I'm just scanning a patient, I don't really need to have a lot of other people in the room. And it's something that I can turn on. It's ready to go quite quickly, and once the patient information is in the machine, we can be up and running very fast. In my practice, for all my fluoroscopic procedures, I do them all over at the hospital in the operating room, so it really requires a lot more scheduling and time in order to arrange those procedures than it does for ultrasound in my practice. Of course, in terms of radiation exposure, that kind of goes without saying if we're comparing ultrasound with fluoroscopy. Another factor to consider with ultrasound versus fluoroscopy is that there is a very good diagnostic component. Again, with this course, we're not really going to be focusing on diagnosis, but there's going to be a lot of things you're going to notice even if you're not specifically meaning to do a diagnostic study. And these two pictures here for my ultrasound machine demonstrate that. The top picture here was from a patient where I was asked to do a shoulder injection, and it was quite evident that they had quite a bit of bursal thickening. So this is the acromion here. This is the humerus. This is basically in a coronal plane over the top of the shoulder joint. So this is the skin, subcutaneous tissue, and deltoid muscle here. And this is their bursal sac, the more superficial layer here, the deeper layer. And you can actually see the bursal line across here. And if this is an area of the body you're used to looking at, you quickly appreciate this is about twice as thick as you would expect it to be. In terms of needle guidance, if you were looking to compare doing a bursal injection with ultrasound versus fluoroscopy, I think ultrasound would be superior without much comparison in that you can distinctly see the bursal sac and opening here, and you'd be able to walk a needle in from lateral to medial and exactly land right in the bursal sac, which is very nice. On this lower slide, this is a glenohumeral joint. So we have the humerus here, the glenoid here. This is looking at it in an axial plane from the posterior part of the shoulder. And in this particular patient, we'll actually talk about this case a little later in the presentation, I was able to immediately see that they had an effusion. And in this particular patient, their x-ray was not as impressive, but their physical exam was suggestive of possible glenohumeral etiology for their pain. And the orthopedist in my practice asked me to do an injection, but he also wanted me to report back to him what I saw from a diagnostic perspective. And the fact that she had a fairly good size effusion was further evidence that perhaps the glenohumeral joint was causing her pain. And I think in both of these instances, this would be information that would be very difficult to obtain if you were using fluoroscopic guidance. Another nice component of using ultrasound for procedures is patient interaction. With a lot of these procedures, the patient's able to look at the screen much more easily than they typically are with a fluoroscopic procedure. And you're able to interact with them, describe their anatomy. And I find in particular this is very helpful with anxious or needle-phobic patients. There's something about seeing their anatomy live on the screen, and ironically enough, seeing the needle enter on the screen that seems to have somewhat of a calming effect. And I find anxious patients really do quite well with most ultrasound-guided procedures. Now, of course, there's factors that favor fluoroscopy. In this picture I have here on the right of medial branch blocks, it would really be quite difficult to get this field of view with ultrasound. Seeing all the needles in place, being able to see all the landmarks from side to side. Of course, with ultrasound, you were looking at a very narrow field of view. It's a very narrow slice through the anatomy and the tissues, and that's certainly an advantage for fluoroscopy, particularly in the spine where you need to appreciate other landmarks simultaneously to the needle advancement. Patients who have a high BMI can create a real challenge for ultrasound. The deeper that ultrasound has to go, you're going to lose a lot of your image quality and resolution. So for example, it's not uncommon that I may be asked to do a hip joint injection on a patient in the office under ultrasound, and if they're over a certain BMI or depending on their particular anatomy and how much adipose tissue they have over the front of their hip joint, I may ultimately decide to cancel that procedure and bring them back and do it under fluoroscopy if I don't feel like I can get an adequate view. In terms of a diagnostic component, I think overall this does favor ultrasound. There are some circumstances where you may appreciate things under fluoroscopy that you would not under ultrasound, and in general this favors osseous structures and joints much more than soft tissues, given that ultrasound provides such a nice view of the soft tissues between the skin and the target area. The image is also less operator dependent in fluoroscopy. With ultrasound, you're basically holding that probe in one hand and the needle in the other, and that requires some degree of coordination. And you also have to be able to find, with that very narrow field of view of the ultrasound, where exactly your target is and get an optimal image. Whereas a lot of times with fluoroscopy, there's a bit of a set it and forget it component where you get your initial image, you have a large field of view to appreciate where you're at, and once you have a good image, for example, with an interlaminar epidural, you don't always have to do a lot of active image work or fine-tuning thereafter. Now certainly for some fluoroscopic procedures, there is a strong operator component. In this picture I have here to the right, getting a good lateral image on a cervical epidural in a patient with a short neck and high shoulders, that does require some skill, and that usually requires some coordination between the physician and who's ever operating the fluoroscope. So it's not saying that there's no operator component with fluoroscopy, but it is a little bit more challenging with ultrasound, and it's going to require some practice and time. The other thing that I think is worth pointing out if we're comparing fluoroscopy to ultrasound, particularly if we're talking about spine procedures, is the issue of reimbursement. Right now, for a lot of spine procedures, you basically have to use a T code or some type of experimental code if you're using ultrasound. And that really favors right now physicians who are at academic centers who don't have to worry quite as much about billing and coding and reimbursement versus folks in private practice who at this point will probably end up using ultrasound quite a bit more for musculoskeletal procedures and nerve blocks and pain procedures that don't necessarily involve the spine, such as an epidural injection or a medial branch block. So for our course, we're primarily going to focus on procedures that you can bill and code and get reimbursed for. But for those of you who have an interest in some of the emerging procedures, we'll certainly be presenting that material as well. So now we're going to talk a little bit about practice integration. Again, this picture on the left is a picture of my procedure room, and I'll just point out a couple things in this picture. Minor things perhaps, but things that I think that with time when you're doing procedures end up being fairly important. One thing is it actually took us a little while to figure out what to use on the window here. This is a south-facing window, and when the sun would come around in the afternoon, the prior shades were those vertical slat shades, and it always seemed like the one blind that was out of place was having to show the sun directly across my ultrasound machine once we had it moved forward and in place. So we actually ended up switching to this semi-transparent black shade, which allows me to see the ultrasound screen very well at all times. In this particular photograph, the overhead fluorescents are on, but when we're doing ultrasound procedures, those are always off, and there's a few small pot lights in the ceiling that are on a dimmer, which provides very nice control depending on the amount of sunlight we're getting in through the window. Because as you can imagine, just like with fluoroscopy, if you have a lot of light in the room, it's going to make your image a little harder to see. Other things that I'll draw your attention to is this is a height adjustable table, and ergonomics are very important, particularly if you're doing multiple procedures a day. So you can raise and lower the patient, and this table also has the ability through a wheel dropping down to be moved if necessary. We do some Botox procedures at my office, so we have a refrigerator here for Botox. And I don't really have a problem with friends or family members being in the room for ultrasound procedures, so we do have an extra chair. And in the case of some upper limb procedures where we might be doing something in the hand and wrist, I simply raise the table up to table height where I can sit on this side. The patient can scoot their chair forward, lay their hand on a pillow or chuck right here on the table, and I can be sitting directly across from them so they're comfortable for an upper limb procedure. As we talk a little bit more about practice integration and efficiency, this is showing the other side of the room that you can't see in this picture, and this is our countertop here, holding sterile gloves. Above it is cabinets holding all of our needles, probe covers, extra gel, all the things that we might need before and during a procedure. And usually when I enter the room, particularly if we already know what the patient's coming in for, my medical assistant already has things drawn up and laid out, which helps keep things moving along in clinic so we don't get behind schedule. We'll talk a little bit more about that in a few slides. So there's, of course, several different factors to consider when it comes to practice integration. First is establishing medical necessity and what kind of procedures you're going to be offering in your practice. And of course, for all of us, that's going to be a little bit different. We all have practices that are a little different. We have different referral sources. And you also have to establish what you're going to be doing under ultrasound and what's appropriate and what would perhaps be inappropriate, and not overutilizing the technology. Efficiency is, of course, important. Even if you're in an academic center, there's still expectations in terms of seeing patients on time, keeping things moving along, and seeing an appropriate amount of patients per day. So you don't want the ultrasound machine slowing you down as you try to add that service line into your practice and offer that modality. Of course, there's dollars and cents issues. What's going to be the cost of the machine, the other equipment you need, if you need to set up a special room, what's that going to cost you in your practice, what kind of billing and coding concerns are there, as well as marketing concerns. So patient population is going to play a strong role in what kind of procedures you offer. As I mentioned earlier, I'm basically within an orthopedic practice, so I have a very strong referral base of musculoskeletal procedures, and I've worked closely with them on establishing protocols. I've also done a lot of lectures with the primary care physicians within my hospital in the geographic area, letting them know what musculoskeletal ultrasound is appropriate for and what it's inappropriate for. If you're within a spine group, your referral base might be a little bit different, and you're going to have to, of course, tailor it to the situation that you're in. For some of you, depending on whether you're at a hospital or a private practice, there could be some potential turf issues with radiology. Fortunately, that has not been an issue at my facility. The radiologists here don't have a strong interest in offering those procedures and don't have necessarily that expertise, and so we get along with each other quite fine. But before you go out and expend resources on an ultrasound machine, those are certainly things to look into, particularly if you're hospital-based and there's a radiology department there who already has an ultrasound machine. I have talked to some colleagues who've been able to work something out with radiology where they use the machine that's already there and they have basically some time sharing with it. Developing some kind of protocols is useful from both a practice efficiency perspective as well as a marketing perspective, so people know what you're offering and why you're offering it. In our practice, oftentimes the orthopedist will start with a non-guided procedure when appropriate. For example, if they're seeing a patient who appears to have some impingement syndrome, they may offer them a non-guided subacromial. If they're confident in their diagnosis but the patient doesn't respond appropriately, particularly if they had a high BMI or other anatomic factors that makes them wonder if the procedure was accurate or successful, they then might send them to me for an ultrasound-guided procedure of that same area. They also sometimes will send me procedures that will be purely diagnostic where they're having trouble narrowing down the pain generator, and they'll send it to me for a series of local anesthetic injections where we might inject the AC joint one week, the subdeltoid subacromial bursa the next week, and perhaps the glenohumeral joint after that if we don't yet have an answer. You also have the option of whether or not you're going to be doing a diagnostic ultrasound in your practice in addition to injections. And I think it's important when you're using musculoskeletal ultrasound to be doing it responsible and establish appropriate medical necessity each time. And I actually have that built right into my procedure template. For those of you who attend the course, I'll be providing some sample templates you can use if you're not already doing that in your practice that will make establishing medical necessity fairly straightforward. Of course, there's efficiency questions, as I mentioned earlier. You don't want this slowing you down. and you'll have to decide what works well for your practice. Are you going to pre-schedule these procedures, as I do in my practice with my fluoroscopic procedures, out of necessity where I'm having to book operating room time? For example, if I'm booking someone for an epidural steroid injection, they see me in clinic for a consultation, we decide we're going to do that procedure, they sign a consent form, and usually within a week or two I'm seeing them in the operating room doing that procedure under fluoroscopy. In my practice with ultrasound, we really do it quite different. Because we have a dedicated procedure room right in clinic, most of the time I'm going to do the procedure right at the time of the consultation. And we're able to do that really without falling behind because we've established some protocols and procedures, and we've done a lot of staff education, and we're able to do the procedure in a very time-efficient manner. And as you can imagine, most patients really appreciate being able to get that procedure on the same day as their office visit. And sometimes it's difficult to predict we're going to be doing the procedure. In some cases, the orthopedic surgeon might be referring to me, and it might say in the consultation request that we might be doing an ultrasound-guided hip jointing, for example. So we kind of know what's coming, and they'll already be in the ultrasound room. In some cases, I'm seeing a patient in follow-up, and I've been previously seeing them for neck pain. They mentioned some lateral hip pain. We ultimately diagnosed trochanteric bursitis. If they have a high BMI and I think a non-guided injection is not likely to be highly accurate, we might just then bring them across the hall for the ultrasound-guided injection. One thing that's important to keep in mind with ultrasound procedures versus non-guided procedures you may be doing in the clinic is you're going to want an assistant. Someone's going to have to be handing you things so you can stay sterile. And someone's also going to have to be operating the machine. You may need someone to change the depth or capture an image. So in most cases, you're really going to want an assistant in the room, and that's something to factor in when you're planning for this. And of course, there's dollars and cents factors here. There's a wide variety of machines out there at a wide variety of costs. There's machines that you can probably get in the teens in under $20,000, and you can certainly spend well over $100,000 for a console-based machine. You, of course, have the option to either purchase or lease the machine, and there's portable machines and console machines and a wide variety of things to look at. As I mentioned earlier, we will be having some equipment representatives at the conference. If you don't already have a machine, you'll be able to look at some different options. And, of course, that's something I'd recommend that you talk to faculty about there as well, what they're using in their practice and what they find successful and helpful. There's other things you're going to need, of course, if you're doing ultrasound-guided procedures. The needles are pretty much going to be the same as to what you're already using in your office, but you are going to need gel. You're going to probably want to use sterile probe covers and a few other things that you may need to get up and running. I talked a little bit earlier about the table you use. I think it is probably wise to have an adjustable height table just for your own ergonomics and patient comfort. There's a variety of different marketing strategies. I've found personally that meeting one-on-one with physicians, explaining to them what we can do, and I've also done quite a few lectures at my hospital and with area physicians, showing them pictures of ultrasound-guided procedures and explaining the pros and cons for particular body areas and procedures. There's billing and coding issues, of course, and some of that's going to depend on your practice situation. If you're in academics, if you're working for a hospital and you're RVU-based, if you're in private practice and you're really just looking at the collections, those are things to consider and things to discuss with the business side of your practice in terms of whether or not this makes sense for you. And of course, and I have had some people email me prior to this course asking me, well, what do you think is going to happen with ultrasound reimbursement in the future? I'm thinking about adding it to my practice. I'm worried about spending the resources on a machine and having a lot of things change in terms of reimbursement. Well, in reality, that's difficult to predict for any part of our practice. And as those of us who do a lot of pain procedures have seen in recent years, that's really changed a lot even with fluoroscopy. So those things are difficult to predict, but of course things to factor in. An example from our practice, we started with a lot of staff training, and that included the front desk staff, because I often find that patients will ask a lot of questions with the folks they interact with at your practice before you get in the room, and they're going to sometimes be afraid to ask those questions of the physician. So they may be asking your front desk staff about ultrasound and ultrasound-guided procedures. They're almost certainly going to ask who's ever doing their intake. So I think it's important for those folks to have appropriate information so they're giving patients correct information. In my practice, I just pretty much have one MA working with me when I'm in clinic, and she's been very well trained in the ultrasound machine. She knows what I need for each procedure, and for new procedures, or if we're going to be adding a new procedure to the practice, I make sure I do some upfront training so she understands what probe we might need for that procedure, what needles, etc., so we stay time efficient. In terms of scheduling, we do a mix of things. Sometimes if the orthopedic surgeon is sending me a procedure, we'll pretty much know ahead of time we're going to be doing an ultrasound-guided procedure that day. In some cases, I might be referred someone because the primary care physician thinks they have a cervical radiculopathy or a lumbar radiculopathy, and based upon my consultation, I think it may actually be a shoulder or hip joint source respectively. We may decide to do an ultrasound-guided procedure on the spot for diagnostic and therapeutic purposes. In the end, having some type of system in your practice which allows you to do these things efficiently, I think will allow you to do it on the fly if that's what you choose to do. We already talked a little bit about having an efficient room setup, having in the room what you need, so if you end up inadvertently contaminating your probe cover, you have more probe covers within a few feet reach, and you can grab a new one and be up and running again. We already talked a little bit about table and patient positioning. As much as possible with ultrasound-guided procedures, I like to have the patient laying down. So even if I'm doing a shoulder procedure where it may seem like it would be better ergonomically to have the patient sitting up, facing away from me, and me on my stool immediately behind them, particularly if you're dealing an ultrasound probe that's sitting on ultrasound gel, the patient doesn't have to move very much for you to lose your image. So as much as possible, I like to have the patients laying down to help keep them in a fixed position, because you're already dealing with a probe that can be sliding around on gel, and it's all too easy to lose your image otherwise. We basically have a very basic protocol at our practice. We make sure the room is cleaned and ready to go. Everything's out that we're going to need. Probe cover, sterile gloves, the needles we're going to need for that particular procedure. Patient's name is already in the ultrasound machine. Preferably, I already like them on the table and in position. I like to pre-scan. So before I do anything with prepping the skin or sterile gel, I first scan the joint because everyone's anatomy is a little bit different, just as we see with fluoroscopic procedures. Everyone is a little bit unique. So I like to know what I'm getting into before we start the actual procedure. And I will mark on the skin where the probe is and where I think my needle is going to enter. And we do non-sterile scanning before we start the procedure. Once we're done with the pre-scan, we clean the gel off the skin and we prep them. We then do a sterile drape of the probe where I'm already wearing sterile gloves. I have my assistant standing by to hand me needles and capture images on the machine. And then when I'm done with the procedure, I can deglove, leave the room. The assistant can then clean up, put Band-Aids on the patient, see if they have any questions, and also find out their anesthetic response if that's going to be important to myself or the referring provider in terms of a diagnostic injection. There's a few other considerations in practice integration. Most of us are now using EMRs, which can overall be fairly helpful. You can set up a few nice templates or one universal template for your ultrasound-guided procedures. And image storage is also going to be an issue. If you're going to be billing for ultrasound guidance, you're going to have some way of storing your image. In the case of the machine that I use, it appears to have a very large memory because in the last 3 years, I have yet to meet the memory of the machine. In every procedure I've done, which is probably on average about 5 per day over 3 years, is still stored in that machine. However, in order to provide for some duplication and make sure we always have a good image and have it in the patient's chart, we utilize a USB drive in our practice, and we basically just put that in the back of the machine about once a week, download the last week's procedures, and then load those directly into our EMR. That way, if I'm seeing a patient back and perhaps they got an unexpected response, or we just wanted to show them the pictures from their procedure, we can bring up the images and review them right there while we're sitting with them in the room. Most machines, as well as the machine I have the ability to also load those images on a hard CD if you prefer that over a USB. And in some places, you may just be able to connect your machine via cable directly to a hospital or institution PACS system and upload them directly in that regard. I'm going to go through a few sample procedures, and we'll be presenting all of these at the course, of course, as well as many others. So the first one I'm going to present will be a glenohumeral injection. So we had a 71-year-old female present to the office, long-standing right shoulder pain after a fall at work. She had had some prior non-guided subacromial injections by an outside orthopedist, and she didn't really get much in the way of relief from that. She also has a history of low back pain and lumbar spinal stenosis, for which I had actually been following her for a while, so I'd seen her before. And she had a past medical history of COPD and diabetes. When I first saw her, I agreed with the outside orthopedist, and by all indications, she seemed to have an impingement syndrome, and most of her pain appeared to be coming from the rotator cuff area and the subdeltoid subacromial bursa area. But unfortunately, she did fail a guided injection in that area under ultrasound. I then had her see one of the orthopedists in my practice for another opinion to see if they had any other ideas for her. And he began to wonder, despite a fairly benign x-ray, if her glenohumeral joint might be her pain generator. And this is actually one of the images I showed you earlier in the talk, where we're able to appreciate a fairly notable effusion off the back of her glenohumeral joint. So in this case, we're not only able to guide the procedure with ultrasound, but it also gave us some diagnostic information as well. So in this picture here on the left, this is an axial plane image looking from the back of the glenohumeral joint. This is the humerus down here, the glenoid over here. You can see her effusion up in this area. This is the skin and subcutaneous tissues here, overlying muscle tissue. And this bright line that you see coming in from lateral to medial is the needle, with the tip being down here. Now in someone without an effusion, you'd essentially be needing to land right in this area at the back of the joint, as there's going to be minimal posterior distension of the capsule. In the case of a patient with an effusion, basically once you cross the capsule here into the effusion, you're basically going to have a successful intra-articular injection. This shows a photograph here of what this looks like. So this is the patient's front, the patient's back, the probe in the axial plane, and the needle coming in here lateral to medial. Next, we're going to talk about a patient with hip pain who required an intra-articular injection. This was an 87-year-old woman with a left greater than right hip pain. She had moderate OA on her x-ray. And I see her about once a year for injections, and she really does very well in the interim. Because of her age, as well as some other medical history factors, she was really hoping to avoid surgery, and she was doing so well with injections. Once a year injections seemed like a very reasonable treatment course for her. This picture here on the left demonstrates the head of the femur, neck of the femur along here. And in these views here, the probe is essentially in a parasagittal orientation. So if you imagine sagittal over the hip joint and then aligning from that point with the neck of the femur, that's the view we're looking at. One thing that's very nice when you're doing these under ultrasound versus fluoroscopy is you're able to see the extent of the hip capsule. And you can see it come down here about halfway down the neck of the femur. And the bright line across here is the needle tracking over from inferior to superior, piercing the hip capsule and landing right here at the head-neck junction. In this image here, you can actually see the steroid solution sitting just above bone and distending up the hip capsule. So as we were talking earlier, you don't always have the advantage of contrast like you do with fluoroscopy, but you often do get a real-time appreciation of where that medication is flowing nevertheless when you're utilizing ultrasound. We're going to talk about a sacroiliac injection. 70-year-old female patient reporting chronic low back pain on the left side greater than the right. She had worked with physical therapy and chiropractic, and when she'd seen another pain practice, she actually had some lumbar facet radiofrequency ablation. They felt like the pain over her sacroiliac areas might be referring from that location. She had been trialing tramadol and Vicodin and had some notable past medical history factors as well. She primarily had tenderness to palpation over the left sacroiliac and PSIS areas. You can see here, this is with a patient prone, the probe orientation essentially in an axial plane, sitting over the back of the sacroiliac area. For landmarks and references, when you're trying to find the sacroiliac joint, it's often useful to first locate the PSIS area. So this would be lateral, this would be medial, this would be the posterior aspect here of the sacrum, PSIS coming up here, and both with ultrasound and via palpation, even on overweight patients, it's usually pretty straightforward to find the PSIS area. Probe is in an axial plane, and then scrolling inferiorly, we're now over the sacroiliac joint, and I think you may remember this picture from a little bit earlier in the presentation. This is the ilium, this is the sacrum, again in an axial plane, looking at it from a posterior perspective. Here's the sacroiliac joint here. This is actually a sacral foramen here, and the spine of the sacrum would be over here. Just to give you a little perspective on that, I'll show you a video of what that would look like, starting over the PSIS, then scrolling down inferiorly over the sacroiliac joint. Now this is showing rolling back up towards the PSIS, and I'll show that to you again. So again, PSIS fairly straightforward to find, both through palpation and with the ultrasound probe. Scrolling inferior to find the sacroiliac joint, and then just to give you some perspective, scrolling back up again. Next patient will be a patient with gluteal pain, 36-year-old female, history of chronic low back pain, but really focusing quite a bit of her pain over the right gluteal area. She'd worked with chiropractors several times in the past, physical therapy, prior pain practice that she saw elsewhere previously, had focused really on her sacroiliac joint. She had some sacroiliac injections under fluoroscopy, which didn't unfortunately provide much relief for her. When I saw her recently, she was pretty much putting one finger right on the piriformis muscle and indicating that both the physical therapist and chiropractor she'd seen also felt that that was the primary pain generator. She did have some prior non-guided trigger point injections which were attempting to target the piriformis area elsewhere. Unfortunately, those had not provided much relief. The video I'm showing you here is a nice illustration of how you can try to localize that piriformis muscle versus some of the other muscles and anatomy in the area. So this is the lateral aspect of the sacrum, just below the sacroiliac joint. We have skin and subcutaneous tissues here. The gluteus maximus muscle is sitting here more superficially. And what I'm doing here with the patient, with the help of my assistant, is we flex their knee to 90 degrees, and with them in a prone position, we're internally and externally rotating the hip. And you'll notice that the piriformis muscle has much more excursion in that situation, and it really helps define the appropriate tissue planes and where you want to target. Show that to you again here, and then this is a picture over here of the procedure itself. So here we brought in a needle lateral to medial, entering lateral to the probe, walking in below the ultrasound probe lateral to medial, going through the skin, subcutaneous tissues, glute max, and then landing the needle tip right here in the piriformis muscle. She had a very nice 100% anesthetic response after a low volume injection under guidance. So we're getting pretty close to wrapping up this evening's webinar. I'm going to review some of the course information for you. So we're going to do a combination of spine, pain, and musculoskeletal procedures. We have 14 faculty, and we have multi-specialty faculty. Of course, this is an AAPM&R course, so several of our faculty are physiatrists, but we also have several anesthesia pain faculty, as well as interventional and musculoskeletal radiology faculty. We're going to be hosting this course on August 24th and 25th, Saturday and Sunday, in Tampa, Florida. We're going to be having it at a state-of-the-art facility, the Center for Advanced Medical Learning and Simulation, which is a University of South Florida facility. Registration rates you can see there. There's some pictures here, one here of the outside of the facility, and here one of the procedure labs. So you can see a very nice facility that we'll be able to use down there. Hotel information. The base hotel for this conference is going to be the Embassy Suites in downtown Tampa. Fairly reasonable rates here for a major city course. And the hotel is pretty conveniently located. It's 1 block from the waterfront. Only 2 blocks from the facility we'll be using for the course. There's a Starbucks at the hotel if you're into your coffee. And there will be complimentary receptions each evening of the course. The hotel also has a 24-hour workout facility and a nice outdoor pool. It's only about 15 to 20 minutes from the Tampa Bay airport. Bars and restaurants are within walking distance of the hotel, and there will also be trolleys running from the course facility to nearby things that you might be interested in. There's a 5-mile waterfront jogging trail in the area, and for those of you who like sports, particularly baseball, it may be useful to note that Friday, Saturday, and Sunday, at times that will not interfere with the course, the Devil Rays will be playing the Yankees there in Tampa Bay. And we hope to see you in Tampa in August, and I hope the webinar was useful in terms of showing you what kind of things we'll be offering at the course, as well as for those of you particularly who haven't done a lot of ultrasound in your practice, some useful information about integrating into your practice, as well as some preliminary information about some of the procedures we'll be presenting. There will also be a promotional postcard going out quite soon, so check your mailboxes, and that will have some further information about the course and registration information, etc. If anyone has any questions, we're pretty much now done with the presentation. We'd be happy to take a few minutes to answer questions. If you don't have questions, I thank you for joining us and wish you a good evening. We'll give you a couple minutes to submit questions if you have them. It looks like we are getting a few questions. I'll give folks time to submit a couple others, and then we can try to address a couple that have been asked. I see one question that's been submitted already is from someone that says they haven't taken any ultrasound courses yet, and should they go to this one or wait for an introductory one? And I have actually gotten some similar questions via email prior to the course, prior to this webinar over the last few weeks. And I think if you have not done any ultrasound at all, this course would be fine. And I think if you're a physiatrist who is a pain physician and you've gone over some of the procedures we're offering and you think those procedures are very applicable to your practice, I would recommend attending the course. The way we've structured the education is even if you haven't done any or minimal ultrasound before, we're hoping that you will nevertheless still be comfortable introducing at least a few of those procedures into your practice right away. And I think you will be fairly comfortable because of the format we're using. So in other words, you're going to be starting with a lecture where you're going to see an experienced presenter go over the anatomy on slides. Then they're going to do live scanning on a screen where you're going to be able to see what they're doing with the probe, how they're positioning the patient, the relevant anatomy. You're also then going to be able to practice that particular anatomy area on a live model yourself in a small group with a fairly small faculty to student ratio. And then you're going to be able to practice the procedure for that area with a needle on a cadaver. Not to mention, if there's 1 or 2 procedures that you feel particularly inclined that you want to bring back to your practice and you want some further practice, we have that additional hour of scanning time at the end of the course where you could pull aside a faculty member and go over those in more detail so you get even more comfortable. I see a question about what cervical procedures we'll be offering. There is an outline of the course on the Academy website. And going over things with Dr. Pingree right now, he's coordinating with some of the faculty in terms of the individual procedures. Things that I have seen that look like they're in the offering for cervical procedures include medial branch blocks, stellate blocks. I know when I mention sometimes trigger point injections, people feel like ultrasound guidance really wouldn't be necessary for that. And I have to say I felt a little bit that way myself before I started doing some trigger point injections under ultrasound, but I've really found that to have a useful tool in my practice. I would say the minority of the time I'm using ultrasound for trigger points, but if you're dealing with an area, particularly the cervical spine, where there's a lot of high-priced real estate, sometimes it's very reassuring for both the physician and the patient to be able to follow that needle live in real time through all the tissue layers. And sometimes I also find that help from a diagnostic perspective. For example, if a patient has medial scapular pain, there's several muscle layers there, and oftentimes I can actually see the twitch response to a particular muscle layer under ultrasound as I see the needle engage that layer, and oftentimes the patient will give me feedback saying, yes, that feels like you're exactly at the spot of my pain. And of course there's multiple muscle layers in the cervical spine as well. I see another question about someone asking if it will be videotaped for attendees to purchase, and it looks like our hosts this evening are indicating that that's not the case. So there will not be videotapes available, it looks like. I'm scrolling through to see if we have any other questions here. I see a question about whether or not this course will be offered in the future at other times. And as the replies that's already been typed in here, I would just echo that. This is very much in development, and some of that will also depend on the feedback we get from Academy members. So if we have a good turnout for the course, we get positive feedback, or maybe someone's not able to make it that particular weekend, feel free to just directly express your interest to the Academy and say, I wasn't able to make it in late August, but this is a course that really interests me. Please offer this in the future. I think the Academy is very receptive to feedback in that regard. I see a question here regarding billing. So there's a few different considerations there. One is whether or not we're talking about diagnostic versus needle guidance. Of course, this course is focusing on needle guidance. The needle guidance code is 76942, so you would use that in addition to whatever code you would normally be doing for that procedure. So let's take a hip joint, for example. You'd normally be coding at 20610. In addition to that, you would put the 76942, which would indicate you utilized ultrasound guidance. This gets a little tricky for some areas. For example, if we're talking about a sacroiliac joint. Now, you used to be able to utilize let me put it this way, you used to be able to utilize different codes than you can now. So that is now needing to be coded as a trigger point, a 20552, with ultrasound guidance, which I think is unfortunate because I don't think that necessarily reflects the work, expertise, and risk involved with the procedure. So particularly for spine procedures, that can get a little bit more complex, and that is something that we will cover in more detail at the course. But for most cases, you'll be using the 76942, which basically indicates you utilize ultrasound for needle guidance. I see another question here regarding piriformis injection. So in the particular case that I presented, and the question looks like in particular it's asking me, was that a, quote, piriformis nerve block? So I suppose there would be some circumstances for certain patients where you may want to perform a sciatic block intentionally. In the case of this particular patient, my goal was to treat piriformis muscle pain, and because particularly in this patient's case, they didn't have a driver that day, it was actually my goal to avoid a sciatic nerve block. One advantage of doing these under ultrasound versus under fluoroscopy, apart from just the greater accuracy in terms of targeting the muscle, is you can usually visualize the sciatic nerve. And as you likely know, sciatic nerve anatomy can be variable. So sometimes it comes out below the muscle, sometimes it's through, sometimes it's over. And in this particular patient, I was able to see that the sciatic nerve was coming out below the muscle. So I actually cheated a bit high in the muscle to intentionally stay away from the nerve so they could drive themselves home, which is, again, a nice advantage to ultrasound. I see another question here asking how this differs from the pre-course at the annual AAPM&R meeting in October. I could be wrong, and the organizers here can feel free to correct me. It's my understanding that the pre-course being offered at the Academy meeting is more of a introductory and musculoskeletal focused course. There may be a small sampling of pain procedures, but I think that course is going to focus more on the limbs and peripheral joints, whereas I would say our course focuses more on pain procedures, proximal joints, spine, and really is geared towards physiatrists and pain physicians who deal quite a bit with back pain and proximal limb pain.
Hi, Dr. McNamara. Yes, that's a very good description analysis there. You're correct.
Thank you. Do we have any more questions? All right, it looks like we don't have further questions. Again, I'd like to thank everyone for joining us tonight for the webinar. I hope you found it useful and a good use of your time, and I wish you a good evening.